Fabulous. Good afternoon, everybody. It's lovely to see everybody join the call this afternoon. I was just talking to Nigel before you joined to say, I'm not sure how many we'll have on the Thursday before Easter, but the number is still rising. So thank you ever so much for taking the time to join. The next in our Quality Support Hub meetings for 2025. So today we have the lovely Nigel with us, who is our honorary treasurer of the IBMS, but also a stalwart of all things quality, and deputy chair of our Quality Specialty Advisory Panel. So it's great to have him with us. He's going to talk to us about metrics, the good and bad of metrics, how to use them and get most benefit from them, but also some of the pitfalls and things that we need to be aware of. I'm sure you'll all get a huge amount from it. And as we go through the session today, please use either the chat or the Q&A. I'll be monitoring both, and we'll pick up some questions throughout the session. I also just want to give you a little bit of a heads up. Our next couple of sessions are rolling towards us. So I'll be hosting the next two, one on May the 15th, where Al Bryant or one of her colleagues from UCAS will attend to talk about both extending or flexible scopes of practice, so that understanding how you can ensure ongoing progress with your UCAS accreditation. And then on June the 12th, Mairead McClellan will join us to talk about ensuring competence. And again, that focus on how we evidence and maintain our competence in line with 15189 2022. So a couple for your diaries. The Quality SAP are pulling together a full programme of works, which we will share and also advertise both online and in the Biomedical Scientist over the coming weeks and months. For today, though, I'll stop sharing. And Nigel, would you like to share your screen?
Yes, just give me 2 seconds just to...
And in the meantime, everybody can get their fingers ready to ask Nigel some challenging questions as we go through the session today. We are only here for half an hour just to try and make these snappy and informative. And for any colleagues that aren't able to join us today, we will be recording. So please let people know that they will be able to access this through the IBMS website. Okay, so with no further ado, Nigel, over to you. Thank you.
Okay, good afternoon, everyone. It's good to see you all. 95 of you now, so that's a really good response. Thank you very much. So just one update. I'm now fully retired from the NHS. I've spent, 45 years in the NHS, and now this is my retirement, working for the Institute and did various things in the Institute. Now I've got the time to actually do it. So what I'm going to talk about is choosing good laboratory indicators. And it's not about choosing good laboratory indicators. It's more about how you interpret some of the indicators and what can go wrong. It's a bit of a soapbox for me because I've seen so many bad practices over the last 20 odd years or so, including the ubiquitous rag rating, which drives him at the wall sometimes, and the way that's being done. And so we're going to go. I'm going to try and leave time for some questions at the end, as Debra said, but we'll see. I'm trying not to get on my soapbox too much. So this is my quick agenda. So we're going to look at the pros and cons of performance and quality indicators, and performance and quality indicators are two different things. I'm not going to go into it too much detail, but usually you can determine which is a performance indicator, which is a quality indicator, by the fact that if you reduce your quality, you can quite often boost your performance. And so that's the way I quickly distinguish between the two. I'm going to talk quickly about balanced dashboards. I'm going to talk about leading and lagging indicators, and then going to provide some practical bits and pieces around checklists and what I would argue is best practice. So all this is based on my experience of doing this. So I really haven't got any references. Oh, we've just topped 100 people, so we're a century of us. First century I've ever had. For those who don't know, I'm a good cricketer, so I've got a good cricket fan, so I'm going to put that in my book. So let's talk about pros and cons and performance and quality indicators, but in the context of healthcare and laboratory medicine. So I've been recently talking to a quality manager who works at Birmingham University. He's an engineer by practice, and he has a completely different view about performance and quality indicators that I have. We tend to have a completely different view in public services. They tend to be quite controversial, and lots of issues with them, which they don't get in engineering companies for some reason. So he's worked for 50 odd years in automotive and aerospace type of engineering companies, and they don't have the issues that we tend to have in public services. So let's look first at the pros of performance and quality indicators. They're said to improve accountability and transparency. Well, they certainly promote transparency. It gives everybody a look to see where we're going. Whether they improve accountability, I'm not quite sure. I was involved in a discussion not so long back which talked about accountability in the NHS and about the kind of lack of it, or how it's changed. It's almost gone from one extreme to the other in my career, from if you get something wrong then you'll be held accountable, to it's more of a learning issue. So yeah, it depends what you mean by accountability. It should support evidence-based decision making, but one of the issues I have with it, it shouldn't replace your professional judgment. You've spent a lot of time learning about your profession and understanding what exactly is going on around you. So you have to look at them in light of your professional judgment as well. It should drive continual quality improvement, and lots of times it doesn't do that because you get the ubiquitous rag rating, and soon as you hit green you forget about it, and you start concentrating on some of the other areas, and it doesn't drive continual quality improvement. It just gets you to a minimum standard. It should enable benchmarking against standards, and I guess the kind of standards I'm thinking of is things like Six Sigma standards, which allows you to benchmark any of your indicators against an international standard, which I see very little use of it in healthcare at the moment. Very prevalent in engineering companies, airline industry, very prevalent, but not in healthcare for some reason. It should promote the early detection of issues. So a little bit of story here. Oh, dog's just going barking at somebody at the door. Apologies there. So I was talking to somebody that was showing me some of their internal quality control, and you can see it going back over about I don't know, probably about 50 odd runs that they've done. But you can see from about 12 runs ago that the 9 or 10 of their quality control was always higher than the previous one, but they'd ignored it because it was in the targets. So they got to the state where it was going higher and higher and higher. It eventually broke the target, and they had to stop using the assay while they sorted all the issues out. And then they got several issues they had, so they did a root cause analysis, dealt with the root cause, but it didn't improve the QC that much. So they've got two failures there: a failure of dealing with their indicators, and then a failure of dealing with of identifying root causes, or causes, I should say, rather than just a single root cause. So if you look at it, they could have picked it up about, at least 7 or 8 runs ago, which was I think they did 2 runs a week of this essay. So 3 or 4 weeks ago, they could have picked it up and dealt something about it. They wouldn't have had the issues that they did in the end. It should encourage goal alignment across teams. So it's really good if you can get your indicators to align with your trust goals, your department goals, your strategic goals, whatever you want to call them. Make sure they are aligned, and finally, it should ensure that you have patient safety and also improve patient outcomes. So I think it's all fairly common. I should say one of the things I'm not going to talk about, actually, I just mentioned this earlier, is things like SPC charts and Levy-Jennings charts and Shewhart charts and things like that. I'm kind of assuming most people would know about those sort of things, and if you don't, you can easily look them up. It's no difficult. I'm not going to talk about Six Sigma really either, but I've mentioned it once or twice. So let's have us continue this with and look at the cons of performance. And this is where I'm in danger of getting on my soapbox. So the biggest issue I have with most of the indicators that you see, virtually every indicator you can have has the potential for being gamed. And you see it very, very frequently. I see it in all sorts of different practices that I've come across, people gaming their metrics. Lord Francis, in his report in the mid-staffs, what was that, probably about 10-15 years ago now, talked about concentrating too much concentration on indicators of various sorts, of gaming them and not using your professional judgment. So I see too many indicators where the aim of setting the target is that they are achievable. So you see turnaround time set at 90%. I just do not understand why you would set a target at 90%. That's on purposely saying that 10% of your patients don't really matter. You're happy for them to get a substandard service while you concentrate on the unknown, and it's all because that's what's achievable. I think any metric that's less than 95% is open to gaming. The higher the target, the less likelihood you'll be gaming. But all metrics can be gamed, all of them, and they are gamed. You can see it very frequently. It can lead to tunnel vision, so focusing only on what is measured. You can't measure everything. So there's an implication that the things that are measured are more important than the things that aren't measured. And you certainly get this situation where, oh, this is a rag rated red, so I've got to do something about it. So we see it often in genetics. Concentration on the turnaround times because they're in the red, and what that leads to is an improvement in the turnaround times. That becomes green, but in the background, the compliance with mandatory training, for instance, turns into red. So you start focusing on that, and then the turnaround times deteriorate. So it's just like a game of, remember that game Whack Attack or something, where you used to kind of whack things across, trying to get them all down at the same time. It's just a game of trying to keep everything green at the end, and then you start lowering the target so you can get everything in the green, because it makes us feel good, doesn't it, if everything's green. A lot of data that's collected for these indicators can be very time consuming. I've met somebody recently who said they had 28 indicators, which it was a fairly small department, which I thought was a hell of a lot in the first place. But just the time taken to collect all the data, most of their time on their indicator was spent on collecting the data rather than interpreting them or taking any actions over them. So you need to be careful that the data collection resource doesn't exceed the purpose and the use of the standard. There's a risk of misinterpretation or over-reliance on the numbers. Again, I can't emphasize it enough. You've got to take these in conjunction with your professional judgments. It's not an excuse to leave your professional judgments at home and just to follow the indicators. Just because it's red, it doesn't mean you need to take action, but you do need to justify why you're taking action and why you're not taking action. It's just equally important. Indicators may not reflect patient experience or context. So turnaround times, I'm a big critic of turnaround times. I'm convinced the only reason we measure turnaround times is because we can. It's easy to do. Everybody does it. It's just, I used to have a constant arguments with my GP. He used to argue about, tell me why why I used to send all the clinical chemistry tests back within by the end of the day, within 8 hours of the sample being sent to us. He says, I'm not going to look at it for another 2 weeks until the patient comes back, and that's if assuming the patient does come back. Often I take blood to give me a bit of time to think, and often the patient doesn't come back because their issues that have dealt. So why are you rushing my GP samples back to you was beyond him. But there you go. I was just a kind of a light-hearted professional discussion with this GP that I was quite friendly with at one time. Overuse can cause staff fatigue or resistance. So this laboratory that had 28 different quality indicators, they spent more time in collecting the data for the 28 than actually interpreting, because everybody's so fed up of doing it. And there was always something that was in the red that they would try and sort out, and then next month they'd sort that one out and something else would be renewed. So it felt like a never-ending chasing the red box, and that's what often quality indicators become. They can often be reduced to just a checkbox exercise. And I've seen that at the institute as well. Often we've had performance indicators that are just presented, and we just kind of note them and don't do anything about them. But I'll come back to those in a second. So not everything's perfect. There are some warning signs that you need to be aware of. So just in summary on that particular purpose, indicators are a powerful tool. They can focus on bits and pieces you need to focus on that are linked to your strategic objectives, but they're not perfect. You can't measure everything, and even if it was desirable and you can do. But you do need a balanced set of indicators, so they need to represent the clinical and the operation and the patient-focused areas of your laboratory work or service that you're providing. And I'll come and talk about balanced set of indicators in a second. They do need, when you look at them, somebody needs to provide with some narrative feedback and your expert judgment about it. So talking about the Institute's performance indicators, we used to get them every quarter, just set a note that we used to note. No, very little discussion about them, very little feedback, no feedback, but I've complained about them several times, but now with them, we've got somebody who's looking at them and providing some detail around them about why the indicators are changing slightly, what decisions we've made to suggest that there's not as bad as we think they are, and things like that. Much more user-friendly and much more discussion about them now. Now we've got the feedback, and we've used a little bit of professional judgment around them. You've got to regularly revisit and refine your indicators. Things do not sit in isolation forever. Life goes on, standards change, expectations change. So revisit them and redefine them, redefine the targets. There's no point be if your targets are all in the green, and then I've been for the last 2 or 3 years, you can kind of question why you've set the targets the way they have. And I've seen laboratories do that as well in the past. Somebody saying, "Well, our indicators have all been in the green for the last 2 years." So, kind of, you're gaming them, aren't you? And you set your targets so low that you're gonna get them into the green, and they'll be successful, and you can ignore them all then. So I've talked about accountability, but I'm also warning about using them as punitive. You take punitive action, so you need to use them so that you can learn and improve. If you're not learning and improving by them, then that becomes a bit of a pointless exercise, and you're doing it to click a quality checkbox of some sort. So let's look at a balanced dashboard. So a balanced dashboard, it's got to be, I think, to have a balanced dashboard, you need to see all the indicators in their entirety. So I've experienced a laboratory that, so I've worked at several laboratories over my career, and I've certainly as a quality man and as a quality manager, I've seen people do their quality indicators on one quality indicator per slide. and you kind of get focused on the wrong things. You don't see them as a whole. You don't overlook at them and see them as a whole, and review them as a whole. So you need to have a comprehensive visual tool that you can see all the metrics at once and where you're going and because as I've said, reiterated once again, you get into this siloed thinking about dealing with just the red ones or the amber ones, and just concentrated on those for a few months, and then everything else that was green turns into amber and red, and those that were amber and red are now green, and you could ignore them for a bit. So you need to keep an eye on the whole lot. So I've talked about strategic decision making. So I like to see quality indicators that cover these 5 kind of key areas. One's about operational efficiency, which is usually where the performance indicators are, along with the financial performance. Quality assurance is you need patient user satisfaction, stuff. It's very difficult if you see this as these 5 areas as a Venn diagram. It's very difficult to get them all to line up appropriately. You end up with them separated a bit, and you just get that fine spot in the middle. Very difficult to increase operational efficiency. We all know the constraints about financial performance at the moment, and the impact that has on quality is very, very difficult to get those all up and going in the right direction at the same time. So you need to have an overview of everything. So I've just here, this probably is not, you've all seen these before. These are kind of key indicators that I've been commonly see in indicating tests. I don't think there's anything particularly different about them. They're all, you've all got something very similar. I'm pretty sure, and you've probably got. So I tend to think about 8 to 12 quality indicators is probably a sensible number. More than that, and you kind of you get into this fatigue or bloody numbers thing type of attitude, and nobody takes too much care of them. So there they are. There's a list there, but I like to see them in a dashboard so you can see them all at once. And I've just this is a summary really. I haven't included everything on a dashboard that I used to use, so I've just picked all the categories and then one metric per category. Although in reality, the operational had 2 or 3, the quality had 2 or 3, the customer services and had 2 or 3, and so on. So there's your target. Often see TAC compliance 90%. So that's just telling me that you're not happy with 1 in 10. You're not going to deal with 1 in 10 patients. You're happy to see them suffer, if you like, and by the time you've not actually risked them, I've seen this as low as 50-60%, which means half your patients are not reaching the TAC compliance, which is absolutely awful. So this is alongside this. I'm trying to get it onto the slide, but it just made it a bit tetchy. I have spark lines. You can develop spark lines in Excel, or some idea of the trends that are going on. I find those much more useful than the actual physical numbers here. So my real one would often have trend lines or spark lines on it to find where the trends are going. So I just provide some tips for implementation. So I've just taken a note of where we are with time. Several tips here. RAG rating. I'll just talk a minute or two about RAG rating because they really get my goat. So we start off with RAG rating, and then we've got RAG rating. We got a yellow in there as well. And then meetings more recently, we've gone, oh, it's not quite red, but it's not quite amber. So we've ended up with red amber ratings and amber yellow ratings. And all of a sudden you've got, instead of a RAG rating where it's really simple, you've ended up with 10 or 12 different things. So the other important things is, and here you need to understand why you're using each metric and understand how you're measuring, how you're collecting the data for each metric. Really important. I used to ask for data about our workload. 3 different people gave me 3 different answers from the same bit of data once, and so that becomes a real problem. So final thoughts on balanced dashboard: breaks down silos between operations quality, promotes transparency and accountability, concentrating particularly on early intervention and continuing improvement. It should be able to drive patient-centered care and lab excellence. So quick mention about leading and lagging indicators. Leading indicators trying to kind of predict in the future. They should be proactive and they should be preventative. So they should be this associated with the risk management system, linked to your risk management system. Lagging indicators tend to reflect past performance, and they tend to be reactive and should be confirmatory of where you are as a laboratory. There should be no surprises in your lagging indicators. You should be aware of them. So you need to use both so you can get a proper view of everything, a balanced view of what's going on. So here's a quick checklist of things. I'm beginning to run out of a bit of time, so I'm skipping through some of these, but you'll all have access to the slides. You'll all have access to the talk as well afterwards. So for each indicator, you need to be able to have this answer this checklist. Why is it relevant? Is it aligned to lab goals? How are you going to measure it? Is it quantifiable, objective, and so forth? So there's various bits and pieces on here that you can have. So a summary of good indicators are that they're relevant to lab goals. They should be measurable with reliable data, and that's easier said than actually done. They need to be actionable, and they should be predictive as well. Timely, you need to make sure you do them in a timely manner. I know one lab that only looked at their indicators once every annual management review period, which I thought was a bit bizarre. You can benchmark them against standards. They need to be clear and simple so people understand. So many indicators I've seen are so complex and complicated, and nuances that need to be taken into account. They are just indicators. They're not if your indicator goes off, then you need to understand why they're not as good as that you think they should be. And just to be aware that all indicators, regardless how well you do, are resistant to manipulation and gaming. So you need to understand that, making sure people don't do that. So I'm going to stop sharing. There's a bit of a rush through it towards the end, but you can visit those, as I said, whenever you want. And I'll stop sharing now. I think I have.
Yeah. You have, Nigel. Thank you ever so much.
Yeah.
And thank you so much for that run through of such a really informative area. I really like the concept, well, dislike the concept that people game their KPIs and their metrics. It's something that we see all of the time, and it's not appropriate. And certainly something, we hear quite a lot about can I add such and such a metric into a dashboard? And my response will always be, why? What's the purpose of it? And what are you going to use that data to prove or disprove? And how is it going to impact patient care? And if you start with that premise around how is it going to inform better practice, then you might get something that you need out of metrics and performance indicators. So yeah, some really interesting concepts. Thank you. Teresa's popped into the Q&A. We haven't got very many questions today, but Teresa has popped in that she's in the middle of rewriting her KPI, quality improvement policy. So if we could share the slides, Nigel, I'll pick that up with you separately if that's okay.
Just, email me or nigel.coles08@gmail. I'll put it in the comments. Hang on.
Fabulous. Thank you.
I can work out how to do that.
I'm sure we can also speak with the Institute to PDF your slide deck and attach them as part of the recording when it's made available.
Yeah.
And Gary's also just posted to say, do you think the lack of Six Sigma in healthcare is funding/cost?
Yes. I think it definitely is. Yeah. It's disappointing to notice that I've heard now 3 different times from 3 different organisations within the West Midlands who have said virtually the same thing in recent times, that we can no longer provide a gold standard service. We've got to learn how to provide a bronze standard service because we just don't have the resources anymore to provide that top quality service, and that's really, really disappointing. So it becomes even more important to find a mechanism to standardize and benchmark our indicators. Just a note from what Debra was saying, I think when people ask, can I add this indicator in, I always ask them to be able to link it to the strategic objectives. If they can't do that, then no.
It shouldn't be there. It shouldn't be there because it's data for data's sake.
Absolutely.
It's absolutely not having any impact. Of time.
Data collecting is ridiculous. How much time I spent. Yeah.
And last one from Helen, would you recommend having increasing goals over time if you're not achieving the 100% target?
So I think all goals should be at least 95%. I think, and you'll pick that up if you link it to Six Sigma. I think even so they said three Sigma is about 67 point. Oh, it's about 64%. So that's the minimum standard in Six Sigma terms. I think all standards should be around 67.5% as a minimum.
Yeah, absolutely.
If it's less than that, it's going to be it's gaming. It's just gaming. It's blatant gaming. Yeah. So I often see standards at 90%.
Yeah.
Sorry.
Pam has put in the chat, and I think it's probably something for us to pick up in the quality SAP, and maybe to pick up Six Sigma as a related topic and something to come back and think about providing some further information or doing a webinar on as well. I think it's definitely something that people would find useful. So we'll look at that and we'll come back to you guys. I would have loved to ask Nigel about PQAD, but I don't think we've probably got enough time today because there's definitely a lot of comments that we could pick up on that one. Anyway, today,
just for the record, I'm not a big fan of PQAD.
For all of the reasons you've outlined in your presentation today, Nigel, as well. Excellent. I'm sure on behalf of everyone that's been on the call today, huge thank you to Nigel for his presentation and his time. I hope you've all found that really, really useful. Thank you for joining. As I say, look forward to seeing you in the middle of May for our next one around extension to scope and flexible scopes with colleagues from UCAS presenting. If you're celebrating Easter, have a lovely Easter. If not, hopefully it'll be a lovely weekend and you'll just enjoy the long weekend ahead of us. For those working, thank you for keeping our services running for the benefit of our patients. Take care, everybody. Thank you ever so much.